we compared some of the sinus rhythms to some of those atrial rhythms, right? So in here, it's still one of our supraventricular rhythms. All atrial rhythms are still supraventricular. So every one of them is still supraventricular. The difference, though, was that when we looked at, that's not the one. That's what I want. When we looked at atrial rhythms, they did not match the sinus rhythm in what capacity? What portion of the strip was different?
P wave.
The P wave, right? We still had a regular rhythm. We still had a rhythm that had normal QRS complexes. We still had a rhythm that had normal PRIs, not necessarily normal, but consistent PRIs. But the P wave was not appropriate. The P waves all matched, but the P wave was not sinus in nature. Either it was inverted in a lead that it was supposed to be upright, or upright in a lead that it was supposed to be inverted, or a combination of a P wave that was mal-shaped, or a P wave that is closer to the QRS complex, so it had a shorter than normal PRI, something that made it abnormal that showed it was not coming from the SA node, is what we saw. So either a mal-shaped P wave, or an inverted P wave, something to that effect. We're looking at this in lead 2, as you can see right here. Told us that we were having a rhythm that's coming from the wrong place. So we call it an ectopic atrial rhythm. Ectopic because the pacemaker site is not coming from its normal place. That make sense? Questions on that? Yes?
Would most atrial rhythms be ectopic because they're not?
All
originating in
atrial rhythms are ectopic.
Okay, that's
Because the ectopy means that the pacemaker is not from the place it's supposed to be.
which would be the SA.
Would be the SA node, that's correct.
Okay.
So all rhythms that don't initiate from the sinus node are ectopic by nature. Some of them we use that word for it, and some of them we don't. We're a little bit not very uniform in our medical terminology with that, but they are all ectopic if they're not initiated from the SA node. Good? Okay, so with that, say it again.
Is that a U wave? On second one?
Right here, that is a U wave. Yep, we'll come back to U waves in a bit later. So, if we have a normal sinus rhythm,
I didn't know this about that.
if we have a normal sinus rhythm, but we have, and this is a terrible illustration, I'm sorry, but that's just the way it goes. If we have a normal sinus rhythm, but we have one area that comes in before it's supposed to, so this is my P to P interval, which means my lines here should line up with P waves, but this one's not lining up with the P wave. It's coincidentally lining up with QRS, which doesn't matter. It's supposed to line up with that P wave, but that P wave is supposed to be here. And my QRS should be here. But it came early, then we have that premature beat, right? And what kinds of premature complexes could we have?
Conducted.
What kinds of premature atrial complexes could we have?
Conducted versus non-conducted.
What does that mean?
So, conducted.
QRS versus no QRS.
No, I was about to talk.
Sorry.
No, I mean, you said I was about to say.
So what is it? Because I still haven't heard it, because I was talking over everyone else.
So, conducted is where you actually have, it's outside the absolute refractory, so you actually get a QRS complex afterwards.
Good.
And then non-conducted, you do not.
Good. So whether we have a QRS complex or not, after that P wave tells us if it was conducted or not. And that conduction means that, what do we mean by conduction? What should you always think when the word conduction is used? What should be the first thing you think of when the word conduction is used in relation to the heart?
Contraction. Electricity is passed.
Polarization.
There's a pulse?
I haven't heard it yet. I still haven't heard it. When the word conduction is used,
It went-
you should think this always with the heart and then go from there.
It went from the AV to the ventricles.
AV, stop, just stop right there.
AV.
Stop it.
When you think conduction, anytime the word conduction is used related to the heart, we are talking about the movement of electricity through the AV node. That's what we mean by conduction, right? When we say the sympathetic system increases the rate of the heart, we are talking about the SA node's effects on the SA node. when we say the sympathetic system increases conduction through the heart, we are specifically talking about the sympathetic's effects on the AV node and its ability to move the signal from one place to the next. Does that make sense?
Yes.
Okay, so if it's not conducted, then it means the AV node was not ready to accept that signal and could not pass it on. If it is conducted, then it means the AV node was past its refractory period, it could accept that signal, and it sent it on. That make sense? Okay. So, we might have something being normal, it's just piling away normally like it's supposed to, and for some reason, another little section of the heart gets excited and reaches its threshold early. That could be from any number of reasons. I've yelled at you many, many times, right, to surprise you on purpose.
Here it comes.
If that happens, all it means is that there's one area of the heart that got its load of norepinephrine, epinephrine, or its release of the acetylcholine by the parasympathetic system withdrawing sooner than other areas of the heart, and therefore it reached its threshold before other areas of the heart. And it fired off. Sometimes it's drug-induced. We provide a drug, caffeine, or some other sympathomimetic, and it happens to get to one just by the sheer chance that this bolus of fluid that's going through your body gets to the heart, and it reaches some part of the heart first, right? And if it doesn't reach all of the heart at once, and it reaches one little area first, that's fine. That area will become excited sooner, reach its threshold sooner, and fire off sooner. And if the heart is in a primed condition, meaning if the repolarization has already happened and the refractory period is already finished, when that one little area reaches its threshold, then it gets control of the heart for that window of time. But if it's transient, like when I surprise you, or if it's transient, like a bolus of drug, like caffeine hitting the heart, and after that moment, everything else is flooded with it, so therefore everything else is getting affected, then the refractoriness of the SA node should come back and take over again, unless there was a problem with the SA node to begin with, right? And so that would instigate a difference in the cycling right at that moment in time and create a premature beat. Simple as that, right? Okay, so the conducted versus the non-conducted.
Do you have a, I'm just looking at the picture on the left right there, I'm just noticing that right branch. Every other, this is kind of off topic, but every other branch we see comes straight down and then back up the outside walls.
Down the septum and then
Down, straight down the septum, both branches come straight down the septum. This one's showing it branches off left sooner.
This is not a three-dimensional picture.
That's what I'm curious, is there a good visual three-dimensional representation that we can look at? Because what I'm trying to figure out is, in terms of electrical conductivity, when you're looking at P waves and QRS complexes, I can see a better three-dimensional.
Yeah, I don't have a model, but I can try to find one. Like this branch right here doesn't come down inferior, it comes around the front.
That's what
And this one actually comes on the back side, it's in the back wall.
Okay.
So this is back and this is in front.
Okay.
That's why it's called the left posterior fascicle and the left anterior fascicle, because this one is coming in front, this one is coming in back.
So in
This one is just going around the wall of the actual right ventricle, which is mostly anterior.
Okay. Because that's what I'm trying to visualize a little more, is how do those electrical currents travel, and obviously it's in 3D. So I'm
Correct.
trying to imagine that fingers wrapping around the heart and where they are.
Yes.
In conjunction.
So this one is coming around the right side,
Okay.
which is mostly an anterior organ, or an anterior portion of the heart,
Okay.
right? Versus this one that's coming this way, and this one that's coming behind.
And then in the atria, it looks like they come more across the heart as opposed to down. I mean,
No, so once again, the atria is primarily anterior, so they're coming in the anterior walls.
okay.
And then we have an inferior version, a middle version, and a superior version of those. Yeah, it's hard to see on a two-dimensional picture exactly where those are traveling.
I mean, I just Googled a three-dimensional picture picture and it's like, oh dear God.
Okay, so Mons, besides conducted versus non-conducted,
Ooh.
what else could we have?
Dun dun dun. Tell us, Mom.
Of a PhD?
Of the PAC? What else could we have? They could be conducted or non-conducted, and either of those could be this or that.
Ooh, I knew I was talking about this.
Oh, that's,
Annalise is going on to phone a friend. She wants to
I
be a friend.
will phone Annalise, or
Oh, you just phoned her. Really
Is
good.
that a perfusing and not perfusing?
no, it's,
well,
That's good.
yeah.
It could be perfusing, not perfusing, and we're feeling a pulse on those.
Right.
Oh.
That's true.
yes.
That's absolutely true. That's not what I'm
Take
going
it.
for, but
Take
that
it
could
away.
be.
That is separate.
Can I phone you?
Wait, that is separate.
Yes.
Separate from conducting versus non.
Yes, the conducting versus non-conducting simply means we had electrical depolarization.
Right.
We very well may not have mechanical flow of blood.
So you could
with
have
us.
that for either one.
You could, yeah, you could absolutely, well, with the non-conducted one, you obviously will have no perfusion for
Right.
that one beat.
Yeah,
For the conducted one, it could be perfusing or not perfusing.
right.
If it's a singular PAC and it didn't perfuse, we don't care. If it's a frequent PAC and it is not perfusing, we do start to care, because then that'll start to affect their cardiac output.
Right.
Yeah, that's true. Rarely do the conducted PACs not perfuse, but it's very possible that it could.
Right.
It's possible that it doesn't. What were you gonna say?
The compensated versus non-compensated.
And what does that mean?
So compensated means, does it march along at the same rate that it was before, or does it increase, or does it slow down, or does it change? So you were talking about with the near car crash, where you have a PAC and then it hopefully returns back to its normal rate, or get in a car crash,
Good.
and it just goes up and up and up.
So a non-compensatory pause means that the PAC will not come back in. The next one after the PAC will not come in when it's supposed to, when it would have come in. So here is my PAC. Here's my P to P interval. My next P should have been here, but it was not because it was a PAC. If I continue to caliper it out, my next P wave should be here, but it's not. It's a little bit earlier than that. And this is back to normal again. Because it's out of time, we say that it's not compensated. The SA node was not compensated, or another way for us to think of that is that this PAC reset the SA node. It got control of the SA node in its process as well. But that one area is done with whatever it was doing, because it was just transient to begin with, and the SA node is back online, but the SA node was reset, so it's coming back online at a different time than it was when it was trucking along over here.
At the same underlying rate, eventually.
Well,
It could be the same or it could be different, depending on what initiated
That's right.
this PAC to begin with.
is it usually like different, more, because that one's kind of hard to tell.
This is a different morphology than that.
Yeah.
But that's the same.
But afterwards, it seems to go into a more Brady rhythm.
So that's
what-
common. It
Yeah.
might, after the SA node is reset, depending on what caused this PAC to begin with, might be an issue. For example, let's say that there was maybe something that stimulated something that vaguely stimulated things. And it started to flood the heart, but it missed this one section, and it kind of reached its threshold first. Or maybe we had a sympathetic stimulation for a moment, and this got affected first, and then the SA node took over after that, right? It's very common for this to be a different tempo afterwards. After the SA node is reset, depending on what initiated and caused that PAC in the beginning, whatever that happens to be.
Is that
Right.
bad?
No, not necessarily. No, it completely depends on what caused it, and most things that cause PACs are completely benign. The only time we're really concerned about PACs, I mean, there are some disease processes that could cause it, but we see PACs so frequently for benign reasons that we don't jump to going, oh, yeah, PAC, we're concerned. But if PACs start happening very frequently, we start wondering why. And if what Annalise and I just had the conversation of, if they happen frequently and they're non-perfusing when they happen, because of the timing of when they happen, then that becomes a concern.
So when we're documenting this we have to say whether it's not compensating or compensating?
So I want you to start paying attention to whether they're compensated or not compensated, yes. Okay. In the end, does that really mean something terrible for the patient? Well, it depends. Depends on if the SA node had something that affected, or if that goes along with other clinical correlations that you have as you're doing everything else. Right now, you're looking at isolated EKGs, so you don't have that clinical side to look at to compare whether or not it's good or bad. So now I just want you to notice it. Versus the compensated pause, and on the compensatory pause, once again, we have our PAC that came in early, or we have our premature beat that came in early, but as we pal out our P2P intervals, it was supposed to come here and it didn't. And then it was supposed to come here and oh, it did. And that means the SA node was not reset. Because the SA node was not reset, the rhythm was compensated.
Why wasn't that
Conjunction.
Because they just threw that out as an example of compensatory. They should.
Bless you.
Okay. Remember that depending on how soon that P wave comes, it might mess up the T wave, right? You might see a weird T wave or something that doesn't look quite right. So here we're seeing this kind of a T wave all over the place, but it looks funky when that P wave comes, and sometimes it can be directly on it to make it look like the T wave is completely different. So whenever you see double bumps in the T wave, or whenever you see the T wave have a different amplitude than all the other T waves, then be suspicious of a PAC. Okay? Be suspicious of a PAC. And it can look any number of different ways, right? So here we've got a P wave coming in. This is where the P wave is supposed to be, right? That's our P wave. This one's different, and that P wave looks different, and it's tucked right up against that T wave. I should have had some space there, and I don't. So that P wave is tucked into that T wave. Or here we have T waves that are supposed to look like this, right? With this amplitude, and note that this T wave has a much higher amplitude to it. And that P wave has a much higher amplitude, it makes me start to think about whether or not there's a P wave tucked in there. And I've got a conducted QRS that looks exactly the same. Wow, okay. I've got a PAC sitting there. In this case, a conducted PAC. Make sense?
Mm-hmm. Mm-hmm.
Questions on that at all? Okay, we did talk about when we're looking at sinus blocks and sinus pauses and arrests, and we have that blank spot. And blocks and arrests happen, but how commonly? How commonly do sinus blocks and arrests happen?
not common?
Not very commonly, right? And we looked at all the things that led to them, and the one thing that can lead to it more often than others is the vagal stimulation. So, you know, if they're vaguely stimulated, then great. But people aren't walking around all day long being vagally stimulated, right? You get vagal stimulation throughout your day at various times, but it's not just oh, hey, everyone here is, how often has everybody in this room been vagually stimulated since noon? Right? You're not, right? But I would imagine that a few of you have had a PAC since sitting in this room, depending on what you're drinking or eating or whatever the case is, right? And so remember that if we have a blank spot sitting here for some reason, I don't jump to assuming a block. Jump to assume a PAC and rule that out. Then if you don't find evidence for a PAC, then you can go and start thinking about some sort of a block or a pause. Does that make sense? So I see a blank spot here, so my first analysis rule is to what? So I'm eliminating this crap. I'll analyze everything else. And now I'm coming back and I'm looking at this crap. I'm looking at it to find out, I find out that I have a normal sinus rhythm, and I'm trying to find underlying rhythm. And so now I'm trying to find out what this crap happens to be, right? If I see a blank spot, I assume a non-conducted PAC first. If I'm assuming a non-conducted PAC, then the next place that I look is where?
On the T?
I look at the T waves. So I'm looking at the T wave right here. Oh, that kind of looks like a T wave. But what do I compare it with?
The other
Yeah,
T
the
waves.
T-wave.
The other T waves. Oh, wait a minute. These T waves all look like this. That doesn't look like that. That is my T wave, and well, that kind of looks like the T wave, or a piece of the T wave. That looks similar, but this is not supposed to be there. But what does that look? What does that look like?
A P buried in
Looking at-
T.
yeah.
Yeah, it looks very similar to the other P waves in
Oh,
some
really?
fashion. So it does look like a P wave. Ah, and that's what I have. I have a P wave sitting on top of that T. It was not conducted because the AV node was in its refractory period when it happened. So I have a non-conducted PAC.
What are you looking at when you're saying that looks like an E wave?
I'm looking at the P waves. and
It's just
comparing it to that.
pointy versus the T waves are round.
Do you not see a similarity in those?
No.
You don't see a similarity in those two waves right there?
They're
Compared
kind
to
of
these
pointy.
ones? Compared to all the other waves that are there? Just this, just that, compared to just this,
I mean, why does it dip down so much?
because it's coming off the
And
QS.
why is it wider?
Because, well, two reasons. One, because it's coming off the QRS. Two, because it's mixed into the T wave. And three, because it's not exactly a P wave. It's coming from a different spot.
Where's
It's
your
coming, it's
T
coming
wave
from a
in that?
different, it's coming from a different spot than the SA node, so it'll be a slightly different
The
shape
T
too.
waves buried.
And the T wave's buried in there, right? So here's my T wave. Here's my T wave. That's the end of my T wave right there. And the start of my T wave is buried along with that P wave. The P wave is happening at the same time as the T wave.
It looks like it's happening earlier than the T wave.
It is, a little bit. Which is why it's not conducted, right?
So why is that not just your T wave?
Because this is what my T wave looks like. This is my ST segment and my T wave. ST segment and T wave. ST segment and T wave. Where's my ST segment and the start of my T wave? It's not there.
Yeah.
Something is there though, but nothing is there anywhere else. Something's there, something's happening right there.
The ST's there, but the P wave is
Covers
a
it.
brighter, a brighter spot to the camera. So that's all the camera sees. So the camera doesn't get to see that ST, it just sees that P. It photobombed it.
Good? On the PACs?
No? Why not?
I mean, I just need, I don't know, I don't get it, but. I
Let's
see
talk a little
how-
bit more after this. Let's make sure you
Yeah.
get those. We'll come back and I'll draw it in just a minute. PACs could be completely idiopathic, meaning we don't know, they're benign, who knows, they just happen. They could be related to things, anxiety, because why?
Because it,
And the anxiety you're feeling from the paramedic is engaging what?
sympathetic system.
Sympathetic.
Great. Fatigue, fatigue and sleep cause all kinds of different, there's a whole process of sleep physiology we can discuss, but fatigue, because it's gonna kind of engage sympathetics and parasympathetics ineffectively. Nicotine, alcohol, and caffeine will all engage it. You could have some heart disease things that leads to it. That's not as common because more people have just simple sympathetic involvement on a regular daily basis than they do heart disease. But when you do have heart disease, you do see these as well. Anything that is a sympathomimetic, so anything that mimics the sympathetic system, or drug or chemical that engages the sympathetic system. And I told you before that digoxin comes into play quite often, so we'll see PACs and digitalis toxicity too.
What would lead to an enlarged atria?
What would lead to an enlarged atria?
Would that be, I mean, would it be just an enlarged heart and the enlarged atria is part of the enlarged heart from
What would
coronary?
lead specifically to an enlarged atria?
High pressure in the lungs.
High pressure in, okay, so if you have high pressure in the lungs, then you'll get an enlargement where?
Ventricle.
Which ventricle?
Right ventricle.
Right ventricle.
Right ventricle, fine. So what's gonna
Oh.
enlarge the atria?
Pressure trying to build into the
Large.
ventricles?
More pressure in the ventricle?
Yeah, so if we have to overcome higher pressures, and that atria has to work harder to get blood to move through the ventricles, you commonly see those things together. Enlargement of the right ventricle will eventually enlarge the right atria as well. But anything that's causing that atria to work harder is going to cause that enlargement. Okay. All right, and then we talked about times in which you see a rhythm that has several different types of P waves associated with it. You do see P waves. Those P waves do seem to be associated with the QRSs. It seems to be a one-to-one relationship. You don't have any dropped QRSs, but the morphology of the P wave is different. There's several different ones. And if we look and see at least 3 different ones, then we would call it this wandering atrial pacemaker. Wandering atrial pacemaker when we see 3 different morphologies of those P waves as we go through it. It is sometimes an irregularly irregular rhythm, and it is sometimes a regularly irregular rhythm. And frankly, as much as I don't want to confuse you, sometimes it actually comes out regular. Because the pacemaking sites can sometimes be so close to each other that you actually don't see a difference in the timing it takes to get to the AV node.
So
But
then-
it could be irregularly irregular, and
So-
it could be regularly irregular.
So if it was a regular rhythm but wandering atrial pacemaker, what would the crap be?
You just see different P
You
waves.
see the different P waves.
But if the P waves are so close together to not
It's
cause.
still telling you that the pacemaking's location has been moving, and that is inherently not good.
Which means that you can have they could be this similar distance apart, but they might be coming from different angles.
Correct.
So the P waves would look different because this spot here and this
Yes.
spot here and this spot here are the same distance, but
Yes.
they will look different.
And that is telling you that the SA node does not have total control over the heart.
Okay.
Although it might be one of the pacemakers, we don't know, but it does not have all of the pacing of the heart. So there are other cells involved for whatever reason. So that's kind of a possibility. There are a couple of different ways that it can go. Kind of the classic definition of wandering atrial pacemaker is this transition, where we start to see different P wave morphologies and different PR intervals as it moves through, and we slowly see a change. Clinically, we just look for any 3 different P waves. We just look for any 3 different P waves, and if we see 3 different P waves, we know it's a wandering atrial pacemaker.
So if you have 2 or less, so you're saying you
Get more of a strip.
get more of a strip, but if you had 2 or less, then you basically say it's just a PAC, even if you have a long strip to it.
We might not be able to tell.
Okay.
Yeah, depending on what that second P wave looks like consistently as we go through, and whether or not it's coming early or late. We might not be able to tell that it's this versus something else. Depends on what we're seeing on the whole strip, of course. Good. So here, kind of this classic looking wandering atrial pacemaker starts with some level of P wave, and you see a difference in those P waves,
Yeah.
and a difference.
Yeah.
Yeah, we see some commonality,
Yeah.
but then it starts to go back down. We're losing the amplitude. We're losing the amplitude. Now it's completely lost. So it goes through a transitional phase with that. So, and this is kind of another version that we can have, and I showed you something like this before, right? Where you have several different pacemaker sites that are all firing, and those pacemaker sites are most likely all firing regularly in and of themselves, but the conglomeration at the end is going to be a mix of everything that's happening. Whichever ones happen to get to the AV node when the AV node is after its refractory period and ready to respond.
Would you consider AFib a version of a wandering atrial pacemaker?
Say that again.
Would you consider AFib
No,
a version of? No.
no, because AFib does not have a singular pacemaker site that gets control of the entire atrium,
Gotcha.
right? AFib has no singular pacemaking site at all, or even several pacemaking sites. It's all of the contractile cells being disrupted.
It's not a flutter, even though it's like,
This
There's
is not,
one
this is not
spot.
circular. You don't see any places that don't have baseline. You see baseline all throughout this. So there's no continuation or circular continuation going on here. Good? Patients that you'll often see this in, COPD patients and patients in respiratory failure, you often see this in. Different types of electrolyte abnormalities can do it. People that are on nicotine or alcohol or caffeine can lead to this because you're stimulating those different cells and can get control over it as they go. And for people that are really young, for kids, you might see it just as a normal variant before their SA node is developed to the point that it's taking over everything.
So is this typically like an asymptomatic, like outward appearance?
So the rhythm itself will probably not be causing them any problems.
Yes.
Their problem is causing the rhythm, and the rhythm is a defining sign that you see to lead you back to the problem.
From
In this
that,
case.
from those?
Could you give an example of that?
Yeah, so you see a wandering atrial pacemaker in a patient, and it confirms that they're having their lung disease problem.
Okay.
Or, let me change that, you have a patient with a lung disease, you might expect to see the wandering atrial pacemaker and therefore would not be looking for it to mean something else. Right? So here's one thing you're gonna have to do in EKG as we go along. There are some EKGs that create the problem, and there are some EKGs that are the result of the problem. If it's an EKG that is creating the problem, you have to take care of the EKG. If the EKG is a result of a problem, you have to take care of the problem. Let me provide you an example of that. Well, before that, just multifocal atrial tachycardia is the same definition that we had for wandering atrial pacemaker, except it's tachycardia. So it's one of our tachycardias. So multifocal atrial tachycardia. Supraventricular tachycardia caused by at least 3 different pacemaking sites. The runs are usually between 100 and 150, but we've seen them as high as around 250 as well. So you just have to just note that. And it's an irregular rhythm.
So you're also showing us that multifocal atrial tachycardia could also be irregular and regular at the same time, if there's like certain 3 spots.
Yeah, you might see a pattern to it. If the AV node creates a pattern off of the timing of when those come, then you'll start to see some sort of a pattern to it at the end.
Okay.
Yeah, that's right. Yeah, so. Yeah.
It says drop beats, block PACs, are those just your non-conducting ones?
Yeah, so it's very common in a multifocal atrial tachycardia that you end up with non-conductive PACs and therefore dropped QRS complexes. Because if I go back to this picture for just a minute, in the tachycardia, right, you might have these different atrial pacemakers coming, and they might get control of the atria when the AV node is not yet ready. And so some of these, you might end up with some of them as just P waves, and you don't have the conducted complex with it because it was premature to when the AV node was ready and past its refractory period. So that's not uncommon. Okay. So we talked about AFib. So one of the things I just mentioned was sometimes you need to treat the rhythm and sometimes you need to treat the condition. And AFib is a really good example of that, right? So there's a lot of things that can lead to AFib. It is our absolute most common arrhythmia, aside from a sinus arrhythmia in the normal variant. It is the most common, let me change my wording. It's the most common dysrhythmia. It's the most common bad rhythm that we see in all of our patients is AFib. You will have hundreds and hundreds of your patients over the course of your career that are in AFib. Lots of different causes for it. Age alone can cause it, right? Other things, MIs can cause it. MIs can cause it. Atherosclerosis can cause it. Digoxin is always there. Heart disease is there. Alcohol, holiday heart. We'll come back to some of these as we talk more about the cardiac conditions. But you can have all kinds of different things that could lead to AFib. Many, many different things. Also, a sinus node that is failing. Many different things can do it. So lots and lots of people are in AFib. And the question is, how bad is AFib really, right?
When you say chronic, does that literally mean their whole life they are
Not
or episodes?
whenever they start to get it, they might have it consistently, and it never gets out of AFib.
So like they die or?
No. Yeah, until they die, or until we do something about it. Until we go in and do a pacemaker, or it depends on if it's causing them problems. We have other patients that will have episodes of it. They'll have a normal, they've got some disease process where they can squeak out normality for a period of time, but then they have episodes of the AFib when that area gets fatigued or that area is disrupted because of activities that they're doing, whatever those activities are.
Have you ever seen someone with just chronic AFib in the sense that it just continues? It's
Yep.
not an episode, it just
Yep,
goes
and
into
often they'll have it for years or for months, and then
That's
it
just
might
how they're
get,
hard.
yep, and it might get to a point where they have to do something about it. You don't have to do, if it's not causing them a disruption in their daily life, then our biggest concern, well, what is our biggest concern?
Clot.
with AFib?
Clots.
Yeah. And
Give
why
them
are
blood-
clots a concern?
because that can cause stroke.
No, I'm sorry. Why is there a concern for a buildup of clots?
Stagnant blood in the atrium.
In where?
In the atrium.
Where?
Anywhere in the body.
Stagnant blood, I want you to be more specific.
In the right atrium.
You know, where? Okay, wait a minute. If there's stagnant blood in the right atrium, where's the blood going next?
Lungs.
Right ventricle.
And where's it going after the right ventricle?
Lungs.
Pulmonary
What do the lungs, and what
embolism.
do lungs do with blood clots?
They have a
Break
PE.
it out.
Anyone know anyone? Lungs? What do lungs do with blood clots?
No, they break it.
Yeah, they filter blood clots. And then where does the blood go after it leaves the lungs?
Everywhere
To
else.
To the left.
the,
Oh,
To the left atrium. And how many clots do we have in that blood?
None.
Not very many, because what do the lungs just do?
Filtered out
So where are we concerned about clots?
in the lungs.
Where are we concerned about clots?
Left
Going into
ventricle.
general circulation.
In AFib, where are we concerned about clots?
Oh,
Where is the location we're concerned about the clots in AFib?
right atrium, left atrium.
The left atria. Why are we concerned about clots in the left atria?
Because then it goes to the rest of the body.
Yeah, because then it goes to the left ventricle. And where does it go from the left ventricle?
The body.
Into the aorta. Anyone know where the blood goes as it enters the aorta?
Everywhere.
Carotids.
I don't want to hear everywhere. Yes, it goes everywhere. Where does it
Coronary
go?
artery.
Coronary arteries or the carotids at the
Yeah.
top of the arch.
Yes, so does it go to the coronary arteries? When are the coronary arteries perfused?
On diastolic,
During diastolic. So what's the likelihood of those clots going into the coronary arteries?
not very likely.
Where does it go when it leaves the aorta? Or when it leaves the left ventricle and enters the aorta?
Carotid.
Yeah, blood flow is directed towards the top of the arch. And what's at the top of the arch?
Carotid.
Yeah, the carotids. Your left carotid is right there. Your right carotid is right there. It comes up and it hits those, and it's very common for it to go into the right carotid or into the carotids. What's our concern about the carotids?
To the brain.
Didn't I say stroke?
You did, and I backed you up to find out why.
Yeah.
Right? Okay,
You
wait,
didn't
okay,
want to know you
so
went to
backing up
Portland, you
again,
wanted to know how you
the
got there.
stagnant blood in the left
I
atria,
just
that
boosted
causes
there.
clots. Then those clots
Just
travel.
teleport.
correct. Stagnant blood's going to be in both
Tom Mons ends
atria.
up most
Yeah.
We are
places.
concerned
He's
about
not, and then he
it
is.
in the left atria. So people that are on AFib, that have AFib patients, if the AFib is not causing them grief, most likely they're going to be on what?
Blood
Blood
thinner.
thinner.
Yeah, most commonly take in daily Coumadin.
What if they're not?
Then that could cause a problem, right? Because of why?
Because they can get a stroke.
Because they can have clots. Well, they can have clots,
Thinking of clots.
I'm just gonna.
which could eventually go to strokes. So
So, but
this is probably true.
But who
It's
knows?
not very common that these people will be in AFib. Why?
Because they probably had a physical.
Strong,
Heart.
oh man, how am I gonna say this? You need a good
Talk about
ejection
everything.
fraction
Good, and
to
what's the
power-
problem in AFib?
You don't have a
power
good
the-
ejection fraction.
What do you lose in AFib?
Lose your preload.
All of it?
No.
How much do you get to get, and how much does AFib?
20%.
take off?
20%.
Yeah, because why?
Because only 20%, the atriums only
Contracts 20%.
contract 20% to load
Maybe-
the ventricles to stretch.
Maybe
So
it was like
atria take care of
17%.
20% of your cardiac output, right? It takes care of 20% of that blood flow into your ventricles that's then pumped out. The rest of it is just pass-through. 80% of the blood is just pass-through blood, right? Great. So either they have to, what do they have to do to compensate? What do AFib patients probably have
Higher
to do
heart
to
rate.
compensate? What's that?
Higher heart rate.
Higher average heart rate to make sure that they're maintaining the cardiac output for a given activity, right? So doing this kind of an activity is probably not something they're gonna do because they're already losing 20% of the cardiac output, and getting into something like this is not something that they could have the cardiac output to do. I mean, the heart rate would have to skyrocket just to manage that, right? But this is fine.
Those are my people.
Absolutely, right? So that's, yeah, that's okay. So here's the issue, and I'll let you go home on this, but what would we be concerned with AFib? When would we be concerned about an AFib patient who is got AFib chronically?
When the rate's too high.
Why?
Because then
The preload.
it won't give it enough time to fill enough to have enough cardiac output.
Give me more.
To perfuse,
The
Don't
preload?
start becoming fatigued chronically, go more and more, but it,
Okay, yeah.
Decreased perfusion, is that
To
what
what?
you're saying?
their brain.
To the heart,
The body?
Yeah, why is there decreased perfusion to the heart?
because it doesn't allow enough time to the diastolic to have the back pressure to the coronary arteries,
Because why?
because it's always beating. It's always, it's a
Okay.
high,
There's more.
yeah.
When does the heart get perfused?
and,
Diastolic.
Why is it getting perfused during dialysis?
Because-
Diastolic.
Because the blood's
Diastolic.
draining, the blood's draining with gravity back down.
Where are the coronary arteries?
Right behind the valve.
Right behind the aortic valve. So if the aortic valve is open and the coronary artery is right here, it doesn't get perfused when those valves are open. It gets perfused on that backflow, that drop in blood flow as the ventricles relaxes, that closes that aortic valve, right? We close the aortic valve, the blood hits that valve and perfuses those coronary vessels. If those valves are open more regularly, right, more often, then that's gonna prevent a good perfusion. And you add on top of that it's already 20% less than it's supposed to be anyway, those coronary vessels get less and less perfusion. So therefore, a slow AFib is better than a fast AFib. Okay, now, I'm not gonna argue with Chris, except for when you take exams or when you're trying to do things on here, right? When you have a fast AFib, we call it RVR. Don't get confused by that. And he was telling you to not worry about that because he's wanting you to not be confused by what that means. Rapid ventricular return. What I'm interested in is whether it's a fast AFib or a slow AFib. A slow AFib is better than a fast AFib, and so I have a patient with chest pain. I have a patient with chest pain.
Always fast.
They are reasonably unstable, and I put them on an EKG and I see AFib on the monitor, right? So I see AFib on the monitor, I have a patient with chest pain, and they're looking like they're moving towards being unstable, and I have to treat them, right?
Is that gonna be our irregular rhythm, narrow complex 130?
All I have right now is a patient with AFib
Okay,
who has chest pain. And now I'm asking you some questions,
Okay.
right? So,
Yes.
when I have a patient with chest pain, how do I treat the chest pain? Oh boy, I better be hearing you yell
Phona.
things now.
well,
Aspirin.
Phona,
Aspirin?
Nitro.
Okay.
Listen
And
along sounds.
consider
Maybe
oxygen.
some morphine, right? Okay, good. Wow.
Fentanyl.
Okay, so that's my chest pain protocol. Does that make sense?
Yeah,
But here's the question that has to be asked. Are they having chest pain because they're having angina or myocardial infarction of some sort, or are they having chest pain because they're ischemic because of the rate? Does that make sense?
Mm-hmm.
So if I have a patient with chest pain, and this is my patient, and this is what I have on the monitor, I don't think the AFib is causing the problem. And I'm going to follow my chest pain protocol. But if I have this patient on the monitor with chest pain, I'm going to assume the rhythm is contributing to their chest pain, and in taking care of this, I'm going to try to alleviate the pain without traveling down the chest pain protocol, or before I follow the chest pain protocol.
Could nitro make that worse for the bottom one?
Could do what?
Could nitro, like, since they're already not perfusing very well,
No, but it wouldn't help.
it wouldn't
Or at least
help,
not a whole lot.
but it
right?
wouldn't make it
If you
worse?
can't control the rhythm, then it's really-
I'm not saying, I'm just saying that if you're already
With the
cornered,
vasodilation.
All that's gonna do is dilate the
Yeah.
vessels.
and they're already not perfusing very well,
Yeah,
correct?
but they're just gonna dilate vessels, it's not gonna ask for more perfusion.
Okay.
Right? So if I have this type of a person, and they're stable, or stable-ish, but having chest pain, I might go the route of what?
Prednisone.
Yeah, some calcium channel blockers to take care of this and see if I
0.25
alleviate their
mg per
pain. Right?
Mhm.
If it's bad enough, then maybe I'll have to shock them out of this.
Mhm.
Good? And then I'll see what's going on with their pain. And if that alleviated their pain, I don't have anything else that I have to do in terms of chest pain protocol. If it didn't alleviate their pain, then I'll travel down the chest pain protocol also. But if this is the issue, I'm not gonna slap them with a bunch of calcium channel blockers, which is gonna slow their heart rate down even more when they don't need that. What they need is me to follow the chest pain protocol. Give them aspirin, nitro, something to